Welcome to Echocardiography lecture series. Learning hemodynamics in echocardiography involves reading in many areas and chapters in the field. I made my best to make this lecture as inclusive as possible. Make sure your coffee is nearby and let's begin. Welcome to Echocardiography lecture series. This lecture is about hemodynamics and echocardiography. It is meant to be a one-stop shop for all hemodynamics and echocardiography. We're going to learn about volume calculations, shunt calculations, area calculations, as well as pressure calculations. We will start by understanding the velocity time integral. This is a spectral Doppler tracing here. The x-axis represents the time and the y-axis represents the velocity of the flow. If we perform integration between velocity and time by tracing the velocity here, if you trace it as shown here, we will get the VTI or velocity time integral, which is 24 cm. It represents the distance that this flow traveled, like 24 cm. So if it means that this flow has traveled from here to here, and the distance is 24 centimeter. Now going to area calculation, the single most important equation in area calculation is the area of the circle, which is pi r square, and the r here is the radius. So let's assume we are calculating the area of the LVOT. We got a diameter of 2, so the radius is 1. So radius we know that equals diameter divided by 2. So the radius is 1. 1 times 1, this is r square, equals 1 times pi, which is 3.14. We get 3.14 square centimeter. So this is the area of this LVOT here in square centimeter. LVOT diameter is measured in left parasternal long axis here, because here it's utilizing the axial resolution, which is the resolution in the y-axis. However, in this image here, we utilize the lateral resolution, or the resolution on the x-axis, which is much less than the axial resolution. So this is the view here, the parasternal long axis view, which is recommended to be used in measuring LVOT diameter. Now the LV stroke volume, or the stroke volume from the left side here, is measured in the following way. Now we know that the VTI is 24, is measured in the LVOT area here. We cannot utilize this image to measure spectral Doppler of LVOT because the angle of incidence here is around 90 degrees, and it will yield a measurement of 0. But here we have a good angle of incidence almost parallel to the flow, so we used this view to measure the LVOT spectral Doppler. And we put our sample volume proximal to the LVOT as mentioned in the previous lecture. Now we got VTI of 24. This is in centimeter. The area here of LVOT is 3.14 square centimeter. If we multiply 24 cm by 3.14 cm, we will get around 75 cubic centimeter, or 75 ml. It represents the volume. So we have the velocity, we have the time, we have the VTI, and now we have the volume. So the stroke volume, or the volume of every beat, is 75 ml per beat. Now if we want to know the cardiac output is defined as the volume, or stroke volume, in 1 minute. So we have to time or to multiply the stroke volume by the heart rate. So stroke volume is 75, and if we look into this ECG tracing, we will see the heart rate is around 59. So 75 times 59, which is the heart rate, it equals 4,425 ml per minute, and we call this the cardiac output. Another way to get stroke volume of the LV is using the method of disc. So we trace the LV and end of diastole. We have an arrow here which is showing a mistake that the sonographer did not trace the LV accurately. So we trace the LV and end of diastole utilizing the biplane and systole and end of diastole. So let's assume that it was 200 ml in end of diastole and 100 ml end of systole. The difference between them is the stroke volume, which is 100 ml. This is true if there is no mitral regurgitation. If there is a mitral regurgitation, this 100 ml will be the total volume that left the LV and the LVOT antegrade flow, as well as the retrograde flow through the mitral valve. So if there is no mitral regurgitation, Doppler method and this volumetric method should be almost equal. However, if there is mitral regurgitation, this volumetric method or method of disc, whether being 2D or even if we do it in 3D, will be higher than the Doppler method. Normal stroke volume will vary. It's between 40 to 120 ml per beat, and the cardiac output again is between 4 to 8 liters per minute. Now we will talk about the mitral valve stroke volume, or the forward volume or forward flow across the mitral valve. The way to do it, we can measure the mitral annular area in apical 4-chamber view, and we assume that it is a circular shape. The time to measure this area or this diameter from insertion to insertion is in mid of diastole, just before the atrial kick. If you look here at the ECG, you will notice that this frame is posed before the A wave. So the mitral valve here will be semi-closed, and we will measure from insertion to insertion, and this will be the diameter. And from this diameter, we will get the radius, and the area of the circle is pi times r square. So now we have the area here in square centimeter. Now we have to put our pulse wave Doppler sample volume in this exact location here. It's not the mitral inflow, it's the mitral annular flow. So we have to put it in this exact place. And then we get a pulse wave Doppler here. We trace this pulse wave Doppler and it will be in centimeter. So now we multiply the VTI times this mitral annular area, and we get the forward volume through the mitral valve. For more accurate measurement of mitral annular area, we can utilize the 3D, particularly if we are doing a transesophageal echo. So instead of assuming a circular shape of mitral annular area, we can just utilize a 3D and trace it and get the exact area here. Mitral stroke volume is not routinely measured in every echocardiography study, but it is very helpful in valvular pathology quantification. The right side stroke volume or forward flow can be done in a similar way of the left one. We can measure the RVOT diameter proximal to the pulmonic valve, this pulmonic valve. So we measure this diameter here. We can either do it in the parasternal short axis view at the level of great vessels, and as well as we can do it in the RVOT, the parasternal RVOT view. So we measure this RVOT diameter, and at the same location where we measure this RVOT diameter, we put our sample volume. It has to be almost at exact location to have an accurate measurement, and then we get the VTI here. So again, assuming a circular shape of this, we can utilize the area of a circle equation, and we can get the volume or the stroke volume across the RVOT. Right side stroke volume can be used as an alternative to LV stroke volume. Also, it can be used to calculate regurgitant volume for the semilunar valve, i.e. the aortic and pulmonic valve. Also, it can be used in shunt calculations. The right side stroke volume as an alternative to LV stroke volume can be used when both semilunar valves are competent. So let's assume this is the pulmonic valve here. Whatever volume will come out of the pulmonic valve will go to the lungs, and from the lungs will go to the LA, and from LA to LV, and from LV back to the aorta. So if 100 ml has left the pulmonic valve here or the RVOT, and this valve is not regurgitant, so nothing is coming back through the same valve, it will reach the lungs and all the way to the aorta, and it will leave the aorta, provided also the aortic valve is competent. Nothing will come back retrograde to the LV. In that case, if we cannot measure the LV stroke volume for any reason, we can measure the right side stroke volume as an alternative to the LV stroke volume. Now let's assume there is a regurgitant semilunar valve. Let's say maybe now the pulmonic valve here is regurgitant. So it will send out 100 ml. And out of this 100 ml, 50 will go back, 50 ml will go back, and only 100 will reach the left side. So if we measure the left side stroke volume, and it is 50 only, so now we can calculate the regurgitant volume of the right side of the pulmonic valve. So we know that the pulmonic valve has sent 100, but only 50 came out of the aortic valve. It means that out of this 100, there is another 50 went retrograde back to the RV, and only 50 reached the left side. In that case, we can calculate the pulmonic regurgitant volume, which equals the pulmonic stroke volume minus the aortic stroke volume. And vice versa, we can use the same thing in aortic valve. So if aortic valve is sending, let's say, 120 ml, and out of this 120 ml, let's say this is the aortic valve, has sent 120 ml, but the pulmonic valve, or the RVOT to be more accurate, is sending, let's say, 70 ml. So where is the rest? Why there is difference? Because this valve is regurgitant, so it is sending 70 only and bringing back 50. So 50 ml will be regurgitant back. So the regurgitant volume through the aortic valve is 50 ml. And now we can calculate this regurgitant volume of aortic valve, and we estimate the severity of aortic valve regurgitation. So normally, the flow from the right side to the left side is continuous. So this is the RVOT, it will go all the way to the left side and back to the right side. It's continuous. So there is no communication between them. It's like a serial. It's not, communicating between them. However, in case of there is shunt between them, now the blood will travel from the high pressure chamber, whether the LV or RV, let's say it's the LV here, the high pressure chamber, to the right side, which is the lower pressure chamber. So in that case, we will have more blood leaving the right side than blood leaving the left side, because now let's say 100 ml came out of this right side. This is the right side, and only 60 ml is going out the left side. So the difference is 40 ml. Those 40 ml is shunted from the LV through some defect somewhere to the right side. And now we can calculate how big is the shunt by doing something called QPQS, or the right side flow over the left side flow. Shunt example is PFO, patent foramen ovale, ventricular septal defect, atrial septal defect, patent ductus arteriosus, and anomalous pulmonary vein. Now to calculate the shunt amount or severity of the shunt, we calculate the QPQS, which is the pulmonary stroke volume divided by the systemic stroke volume. So whatever stroke volume from the right side divided by the stroke volume of the left side. So if it is 1 or almost equal to 1, there is no shunt. If it is more than 1, so it means that the stroke volume from the pulmonary side is higher than the stroke volume from the systemic side, or the LV stroke volume. This is how we calculate it, the RVOT stroke volume as shown previously divided by LVOT stroke volume. So if it is more than 1, it means there is more blood leaving the RVOT than leaving the LVOT. So that excess of blood must have shunted from left to right. So there is a left to right shunt. However, if it is less than 1, it means there is more blood leaving the LVOT than blood leaving the RVOT. So this axis is shunting from right to left. So we call it right to left shunt. This is true with one exception, and that exception is PDA. So as shown previously, the way we measure QPQS, or the stroke volume from LVOT and stroke volume from RVOT. But now, let's say this is the pulmonary artery, and this is the aorta somewhere here, and you do the measurement here, and you do the measurement here. Let's say this is LVOT, and this is RVOT. And the shunt location is distal to the measurement side. It will be somewhere here. So excess blood will shunt from left side to right side. It will go to the lungs, and from the lungs it will reach back to the LV. So now you will have more shunt or more blood leaving the LVOT than leaving the RVOT, but it is still left to right shunt, because this measurement site is distal, or the shunting side is distal to the site where we do our measurement. In case of ASD, we can use the conventional way of QPQS that we just saw, or we can use, maybe we trace this ASD. Now we have the area, and we trace the flow. Now we have the VTI. So VTI times the area, we can get the shunt volume. So this is the shunt volume. This is the volume that goes from LA to RA. So let's assume it's 50 ml. So 50 ml will leave the left atrium and goes to the right atrium. So now QPQS will equal, let's say you measured the LVOT stroke volume and it is 60 ml. Okay, so the right side stroke volume will be 60 ml plus the extra 50 it received from the left side. It will be 110 ml, and QPQS will be 110 divided by 60. Now area calculation by continuity equation. The continuity equation is based on the fact that whatever volume comes in will go out. So let's say that 70 ml came here, so 70 ml has to go out from here. The difference is it might come here at lower velocity, and if there is a narrowing, the same 70 ml will leave here but at higher velocity. And by knowing that, we can calculate this area. So again, whatever volume comes in will go out. So volume in equals volume out. So VTI times the area 1 equals VTI 2 times area 2. So if this is area 1, we have to measure VTI at this area. So we put our sample volume in this exact area, which is, let's assume this is LVOT, the same way we saw it, and this is the aortic valve. And because we are interested in the smallest area, we need to measure the highest velocity. And the way to measure the highest velocity is not by utilizing the PW, and instead we will use the continuous wave Doppler to give us the highest velocity. So in this example, we have the pulse wave Doppler to get V1. If we trace it, we get VTI. So it will be VTI1, and this is continuous wave Doppler. We can get it in apical views in aortic valve, and we have the VTI if we trace it. Sometimes we use the flow rate. It is less accurate than the VTI. Flow rate is velocity. So if we have velocity times area, it's not VTI times area. If we do velocity times area, we will get the flow rate, which is ml per second, or cm cubic centimeter per second. We call it the flow rate. So whatever flow rate comes in will go out, and we use this in PISA or proximal isovelocity surface area calculation. I will show you this in the coming slides. So by knowing the VTI1 and the area 1, we know it because we measured it. We know VTI2, it's from the CW. We are interested in this area. So now we can get maybe the aortic valve area by utilizing the continuity equation. We can utilize the continuity equation in any valve. Let's say now we have a mitral valve here, and this is the LA. So if we calculate the stroke volume of the mitral valve, the same way we have seen, let's say it is 70 ml, and if the mitral valve is competent, i.e. there is no regurgitation or no significant regurgitation at least, we know that 70 ml again will go through the aortic valve. So we can use this 70 ml as a stroke volume. So 70 ml divided by this VTI of the aortic valve, we get then the aortic valve area by continuity equation. Okay, let's assume the mitral valve has significant regurgitation. maybe it will send back around 30 ml. So this regurgitation will not pass through the aortic valve. It will go to the LA. So 30 ml back, and only 40 will pass through aortic valve. We don't know this, but we know that there is significant mitral regurgitation. In that case, we cannot use the mitral valve to calculate aortic valve area because there is significant mitral regurgitation. However, let's say the regurgitation now is present in the aortic valve itself, and in that case we utilized the LVOT. It is the LVOT stroke volume we used, but the aortic valve has regurgitation. This is the aortic valve. So the same volume which will come retrograde from aortic valve, it will reach the LVOT. So this regurgitant volume will pass through both areas that we measured. In that case, even the forward flow, it will go through both of them. It will go through the LVOT and the aortic valve. So in case of aortic valve regurgitation, we still can use the continuity method from LVOT to calculate the aortic valve area here. So again, we said continuity equation will assume that the same volume flow through all valves if the valves are competent. Let's assume again now we have mitral regurgitation, and we calculate the mitral stroke volume here as 70 ml, and the aortic valve we measured the LVOT stroke volume. So this is the LVOT, and we measured the stroke volume here, and it is only 40 ml. So there is difference, and we have seen by color Doppler that there is mitral regurgitation. So now we can calculate something called the regurgitant volume. So regurgitant volume in that particular case will equal 70 ml that came out of the mitral valve, but only 40 reach the aortic valve or the LVOT. So what happened to the remaining 30 ml? It regurged back to the left atrium. So now its regurgitant volume equals 70 minus 30 or minus 40 equals 30 ml. Again, in regurgitant, now we can utilize this 30 ml to see or to estimate the severity of this mitral regurgitation. The same thing we can do in any valve. Let's say now the regurgitant valve is not the mitral, it's the aortic. So this is the aortic valve here. We know that it has some regurgitation demonstrated by color Doppler, and we calculated the stroke volume in LVOT, and it is 100 ml. However, if we calculate the mitral valve stroke volume, let's say it is 50 ml only. So 50 ml, and the mitral valve doesn't have any significant regurgitation. So 50 ml will come out from mitral valve and will come out from the aortic valve. So what happened? Where is the remaining 50? So the remaining 50 is the regurgitant volume of the aortic valve, because now 50 ml will come out of mitral valve. It will join another 50 that regurged back retrograde through the aortic valve. Now the total is 100 that comes out of the aortic valve. So now regurgitant volume in that case will equal 100 minus 50. So the first always is the regurgitant valve, and the second one is the competent valve. So it will be like this: regurgitant volume equals stroke volume from regurgitant valve, regurg, minus stroke volume from the competent valve. Proximal isovelocity surface area is another form of continuity equation. So as we mentioned earlier, that flow rate N equals flow rate out. There is one phenomenon that, if there is an opening, let's say this is an opening here, this opening here, and flow is coming through that opening. So the closer the flow to the opening, it will increase the velocity. Not only that, it will form a hemisphere like this. This is fluid dynamics. So when the flow reaches an opening, it will accelerate and form a hemisphere. So, and the velocity of the surface of hemisphere is constant. So the velocity here equals here, equals here, anywhere in the hemisphere. And the closer we come to the orifice, the higher is the velocity. So we have, this is higher velocity here, and lower velocity will be here when we go away from that orifice. Now we can utilize this as continuity equation to calculate this orifice area. If we know the velocity here and we know the area, so we know the velocity, let's assume we know this velocity, and the area of a hemisphere, we know it, and we know the velocity that it exits this opening, we can calculate the remaining area of the opening. We will see this in the coming slide. So this is the same thing that we talked about. This is an opening here, we call it A2 or area 2, which we would like to know. V2 we can directly measure by continuous wave Doppler, and V1, which is the velocity of the flow at the surface of this hemisphere. So this is a hemisphere, and V1 is the velocity at the surface of this hemisphere. How to know this velocity? We change this Nyquist limit here to decrease the velocity in order to change color when it exceeds or reach that exact velocity. In that case here in this example, it is 30 centimeter per second. So we change it here. So whatever reaches 30 centimeter per second will change color from blue to red or yellowish tint. So now we know that everything on that surface is 30 because we already made the settings. The area of hemisphere, simply we measure this radius. And if you remember, the area of a circle, which is the most important equation, is pi times r squared. We just multiply it by 2. When we multiply it by 2, we get the area of hemisphere. So area of hemisphere is 2 pi r squared. And again, continuity equation. V1, which is the Nyquist limit, times A1, which is this one, area of a hemisphere, equals V2 times area 2. And how to get V2, we will see it in the coming slide. So again, we just put our continuous wave Doppler through the regurgitation here, or the flow, and we measure the peak velocity. And we use the peak velocity. We cannot use the VTI here because we put velocity here, we have to put velocity here. However, we need to make sure that the velocity we measured here, we have to convert it from meters to centimeters. because we used here centimeters and the flow is ml per second, so we need it in centimeter. After we get the area, now we know the area. If this is a regurgitation, we call it effective regurgitant orifice area. If it is a stenosis, we call it effective orifice area. So now we have the area from continuity equation. Now if we multiply this area by this VTI, so the area again is in square centimeter. If we multiply by VTI, which is in centimeter, we will get the volume, which is here, in that case, is the regurgitant volume. Now we'll shift gear and talk about pressure calculations. So pressure calculations are based on the Bernoulli equation. And we already talked about Bernoulli equation in the physics. The pressure gradient is the difference of pressure between two chambers. So for example, let's say this is the RV here. This is the RV, and this is the tricuspid valve here, and this is the RA. And if we put a CW or continuous wave Doppler here, we will get, let's say, a regurgitant spectral Doppler, and we can measure the pressure gradient utilizing the Bernoulli equation. It means that the difference of pressure between the RV and RA is such. Let's assume the velocity here is 3 meters per second. Now, utilizing the Bernoulli equation, we calculate the pressure. It will be 4 times 3 squares, which is 36 millimeters of mercury. It means that the RV is higher, the pressure of RV is higher than the RA, sorry, this is the RA, by 36 millimeters of mercury. So RV pressure minus RA pressure equals 36 millimeters of mercury. And this is true because the flow direction will determine which has the higher pressure. So if the flow is directed from this chamber to this chamber, it means that this chamber has a higher pressure than this chamber. This is why in diastole, the RA pressure is higher than the RV pressure, and we have the flow goes from RA all the way to the RV. Now we'll see a few examples of pressure calculations. We'll start by RA pressure calculation as well as estimation. We can estimate the RA pressure from the IVC or invasive estimation. If present, P of O or AST can help us also. And the jugular venous pressure can be helpful in estimation of RA pressure. And this is how we estimate the RA pressure from the IVC. We record the IVC for like 10 to 15 seconds, and we observe the size as well as the collapsibility. So to measure the size, we measure the maximum size, the bigger size, around 1 cm to 2 cm away or proximal to this hepatic vein. So we see this hepatic vein, so we measure it around here. And we measure then collapsibility with sniffing. So we ask the patient to sniff, and we observe how much the IVC collapses. So if the size is 2.1 or less, and it collapses more than 50%, we will estimate RA pressure as 3 millimeters of mercury. If the size is still 2.1 and less, but it collapses less than 50% of the original size, we estimate it to be 8. And if the size is large, more than 2.1, and it collapses very well, we still estimate it to be 8. But if it is large and even does not collapse very well, we estimate the RA pressure to be 15. The jugular venous pressure is a clinical measurement of central venous pressure. It is done clinically, and a lot of physicians, they do it. And the problem with it, you measure the central venous pressure in centimeter of water. But we need the RA pressure in millimeter of mercury. So we have to use a conversion. So this is the conversion equation. We divide it by 1.36 and we convert whatever we measure in centimeter of water, the JVP measurement. So let's say the JVP is 10 centimeter of H2O. We have to divide it by 1.36 to get it in millimeter of mercury. Also, the RA pressure can be measured invasively if there is, like in case of intensive care, and there is a catheter to measure the central venous pressure. It can be used as an estimate for RA pressure. RA pressure can be measured if there is a PO4, ASD, given the fact that we know the LA pressure. If we know the LA pressure, we can measure the RA pressure. So in case of RA pressure, in case of left to right shunt, so the LA pressure is higher than the RA pressure and the direction is from left to right, we measure it by utilizing this equation. RA pressure equals left atrial pressure minus this peak gradient. It's not a volume, so we don't need to trace it. We just measure the peak, the highest gradient or the highest velocity, and we calculate the pressure gradient from that. If the RA pressure is higher than LA pressure, the direction will be reversed, and RA pressure will equal LA pressure plus this the pressure gradient between the two chambers. Enough of RA pressure. Now the RVSP, or right ventricular systolic pressure, and PASP, which is the pulmonary artery systolic pressure. It can be measured from tricuspid regurg and from VSD. So now estimating the RVSP from tricuspid regurgitation. First of all, we have to utilize all available windows that can give us a tricuspid regurgitation flow. And we use a very good flow. We cannot use a flow like this because it will either underestimate or it will not really accurately estimate the RVSP. So this one is no. If we have a good flow like this, we can measure the RVSP by measuring the peak velocity and convert it into pressure by Bernoulli equation. Now this pressure will represent the difference between the RV and RA. So the RV is higher than RA by this much. So RVSP will equal this pressure, tricuspid regurgitation, plus the estimated RA pressure, which we just have seen in the previous slides. Now, in case if we have a severe tricuspid regurgitation, this relationship between RA and RV pressure gradient will be distorted, and we cannot utilize this method to accurately estimate the RVSP. In case of the presence of VSD, we can utilize a VSD to estimate accurately the RVSP. The flow gradient between the LV and RV can be estimated by putting a continuous wave Doppler along the VSD flow. So now we know that the difference between RV and LV is this much. What we need to know is the LV pressure, LV systolic pressure. Now, if there is no aortic stenosis, the LV systolic pressure will equal the systolic blood pressure. So if we measure the systolic blood pressure, we can now estimate the RVSP. So RVSP now will equal systolic blood pressure, which is LV systolic pressure, in case of, again, if there is no aortic stenosis, minus the VSD gradient. Pulmonary artery systolic pressure is exactly the same as RV systolic pressure, and it will equal the RV systolic pressure given that or there is no pulmonary stenosis. In case of there is pulmonary stenosis, the case is different. Now RVSP, RV systolic pressure, equals pulmonary artery systolic pressure plus the pressure gradient between them. So we have to utilize the pressure gradient. If we need to calculate pulmonary artery systolic pressure from RVSP in case of pulmonic stenosis, it will equal RVSP minus the pressure gradient, the PS peak pressure gradient between them. Okay, so now what we do with all these numbers. So the normal, we can use it if there is pulmonary hypertension. So the normal pulmonary artery systolic pressure is less than 40. Between 40 and 50 millimeter of mercury is mildly increased, 50 to 60 is moderately increased, and more than 60 is severely increased, given that it is more than 2/3 of the systemic systolic blood pressure. So if the blood pressure is 200 over 100, so 200 is the systolic, and let's say the RVSP or pulmonary arterial systolic pressure is 70. It is moderate, it is not severe, because it's not 2/3 of the systemic systolic blood pressure. So it has to meet two criteria. One is more than 60, the other one is more than 2/3 of the systemic systolic blood pressure. Pulmonary artery diastolic pressure is an interesting measurement, because now this diastolic pressure gradient or end diastolic pressure gradient, this is a PR jet. So it represents the difference between the pulmonary artery, this is pulmonary artery, and this is the RV. So it represents the pressure difference between the PA and RV. And since it is an end of diastole, where the tricuspid valve is open and there is no much flow between the RA and RV, we can use RA instead of RV-EDP, because RA now pressure will equal RV-EDP. It's the same. We can estimate RA pressure from IVC or any other method of estimation, and by estimating the RA pressure we can know or estimate the pulmonary artery diastolic pressure. So pulmonary artery diastolic pressure will equal the pulmonary regurgitation end diastolic pressure plus the RA pressure, because it is higher than RA, because the flow is from PA to RA or to RV. So it will equal pulmonary regurgitation end diastolic pressure, which is somewhere here. We have to measure this pressure here, adding to it the RA pressure. The mean pulmonary artery pressure can be very important, and we might really need to measure it by echo in some cases. We can measure it by the mean formula or the acceleration time, the pulmonary regurgitation early diastolic pressure, as well as from the mean tricuspid regurgitation pressure. Remember this pulmonary artery diastolic pressure we have seen few slides ago. and we wonder what's the utility of this measurement. And here comes the utility. Now we can use it to estimate the mean pulmonary artery pressure by utilizing this mean formula, because since the diastolic phase constitutes 2/3 of the cardiac cycle while 1/3 is during systole, the following equation can be utilized. Now the mean pressure will equal 1/3 of pulmonary artery systolic pressure plus 2/3 of the pulmonary artery diastolic pressure, and we get the mean pressure. Another way to estimate or measure pulmonary artery mean pressure is by acceleration time. And the theory behind this is the higher the pressure is in the pulmonary artery, the quicker the flow will abort and it will reach its maximum velocity quicker. The way to measure it is we put our sample volume and just proximal to the pulmonic valve, and we measure it with pulse wave Doppler. It is measured from the baseline 0, where the flow starts to begin, all the way to its peak. So, and we measure this time here, this period from 0 to peak. And this is the acceleration time. We measure it in milliseconds. If this acceleration time is 120 milliseconds or more, we use this formula, 79 minus 45% of the acceleration time, and we get it in millimeter of mercury. If the acceleration time is less than 120 milliseconds, we use this formula, which is 90 minus 62% of this acceleration time. Also, measuring the pulmonary artery mean pressure can be done by measuring the early pulmonary artery diastolic pressure. Now, it's not the end of diastole, it is the very early part of the diastole, here, once the diastole begins. So once systole finishes here and diastole begin, this is the mean artery pulmonary pressure. And the way to do it, because this is the difference between the pulmonary artery pressure and the RV or the RA pressure, we will utilize the RA pressure as a surrogate for the RV pressure. So the mean pulmonary artery pressure will equal this pressure here plus the RA pressure. Final method to measure pulmonary artery mean pressure is the mean tricuspid pressure. As we have seen before how to measure the RVSP, because it's the peak systolic pressure. Now if we trace the tricuspid regurgitation jet, and instead of having the peak, we trace it now, we get the mean. And from that mean, we add to it the RA pressure. So the mean tricuspid regurg plus RA pressure, we will get the mean pulmonary artery pressure. Pulmonary artery vascular resistance can be very important, particularly in indication and contraindication of shunt closure like an ASD or VSD. The way to do it in echocardiography, first we have to understand the theory behind it. So if this is the RV here, and this is the RA, and this is tricuspid valve, and this is pulmonary artery, and this is pulmonic valve here. So this is the pulmonary artery. The higher the PVR, or pulmonary vascular resistance, the lower flow will go forward, because now we have high resistance, and more flow will go backward through the tricuspid valve even at a higher velocity. By understanding this only, we can understand the origin of this equation. PVR in Wood's unit will equal tricuspid peak velocity in meter per second divided by the RVOT VTI, and we get RVOT VTI just proximal to the pulmonic valve, times 10, and everything we add 0.16 to the sum of this. By doing that, now we get the PVR in Wood's unit. This is, in this equation, it will lose accuracy if the PVR is more than 8 Wood's unit. Now I will tell you about Doppler signs of pulmonary artery hypertension. So if we have this notch or this dip, we call it diastolic dip. This diastolic dip here and here and here can be seen in pulse wave Doppler and in continuous wave Doppler. When the atrium or RA contracts somewhere here, this is the P wave, it will generate pressure, thus increasing the RA pressure and then the RV pressure. And by increasing the RV pressure, this is pulmonary regurgitation. Now it will almost abort this pulmonary regurgitation. By knowing that this small increase in pressure was sufficient to cause this indentation or this dip, it means it is very unlikely to have significant pulmonary artery hypertension. In case of loss of this dip, it might indicate significant pulmonary artery hypertension. On the other hand, if we have a notch in the systolic forward flow, like let's say we put an pulse wave Doppler in the RVOT and we see this mid-systolic notch here, it indicates significant pulmonary artery hypertension, that it almost aborted this forward flow. Now we will further shift gear to the left side pressure estimation, starting with the left atrium. So left atrial pressure can be estimated from aortic regurgitation or mitral regurgitation or the presence of PFO or ASD. LA pressure from aortic regurgitation. So in the absence of mitral stenosis, now the LV diastolic pressure, particularly the end diastolic pressure of the LV, approximate the LA diastolic pressure. In the presence of aortic regurgitation, the end diastolic aortic pressure resembles the aorta LV end diastolic pressure gradient. So if we measure the blood pressure, and this is the diastolic pressure, so this diastolic pressure is the pressure in the aorta. So this is the aorta, and during diastole or end of diastole, the pressure here is 60. Okay, now if we have aortic regurgitation and we measure the pressure at the end of diastole here, and it is 40. So now we know that the difference between the aorta and the LV, this is the LV, is 40. The aorta is 60, the difference is 40, so it means that the LV end diastolic pressure is 20. It means the LA diastolic pressure is also 20 in the absence of mitral stenosis. So as we mentioned, the LA pressure will equal the LV EDP. In case of mitral stenosis, we need just to add the mitral stenosis mean gradient to get the LA pressure. So the equation will be LA pressure will equal LVEDP plus this mitral stenosis mean gradient here. So in that case, if we go back to the example before, the LVEDP is 20, and here the mean gradient is 60, so the LA pressure will be 26 millimeter of mercury. Another way of estimation of LA pressure is from mitral regurgitation jet. As we know, mitral regurgitation will represent the pressure difference between LV, this is the LV, this is the LA here, and this is the mitral valve. So if we know the systolic blood pressure, let's say the systolic blood pressure in this example is 130 millimeter of mercury, the patient blood pressure is 130/70. Okay, so we know that LV now, in case of there is no aortic stenosis, if there is no aortic stenosis, again LV pressure will equal systolic blood pressure. So now LV is 130. The difference between the LV and LA is this MR peak pressure gradient, which is 123. It means that the LA pressure is 130 minus 123 equals 7 millimeter of mercury. In the presence of aortic stenosis, things can be really complicated. Let's say that this is the LV here and this is the aorta here. This is the aorta and this is aortic valve, and there is significant stenosis. So we have a gradient, and if we measure this gradient with our continuous wave Doppler, let's say it's 40 millimeter of mercury. However, it is not correct just to add systemic blood pressure in systole, let's say systole, plus this 40 will equal the LV systolic pressure. This is not correct. I will tell you why. The problem is what we measure in systemic blood pressure is here. It will peak later in the presence of aortic stenosis. It will peak later than the LV. So we have, this is the LV peak here, and this is the aortic peak. What we measure, let's say this patient blood pressure is 160/90, so we measure it here at this point. This is the 160 here. By doing continuous wave Doppler, this is the gradient what we measure. We measure it here. So what we need to do, we need to correct this gradient to shift it rightward to coincide with the peak of this systolic blood pressure. How to do that? The usual correction or the factor is around 70%. So we have this peak instantaneous gradient. Let's say the gradient is 40. Now we have to time or to multiply it by 0.7. So again, the systolic blood pressure will equal the peak pressure of the aorta, which is here. Now the peak instantaneous gradient is measured by continuous wave Doppler, the peak AV gradient. Here, this is the peak instantaneous gradient through the aortic valve. The LV systolic pressure will equal the systolic blood pressure plus peak to peak gradient, this small gradient here, not the higher gradient here, not the peak instantaneous. This is different. So we need to convert the peak instantaneous gradient from here. We convert it into peak to peak gradient. The way to do it is we multiply by a correcting factor, which is 0.7 or 70%. So peak to peak gradient will equal 70% of the aortic valve gradient. Remember that this pressure here is not the aortic valve pressure, is maybe the brachial artery pressure. In that case now, LV systolic pressure will equal the aortic valve gradient times 70%, and we add to it the systolic blood pressure. Now we have the LV systolic pressure. From MR we can now estimate the LA pressure. So let's see an example to understand it even more. In this example we have a patient with blood pressure of 140/90 millimeter of mercury. We are interested in his LV systolic pressure or LV peak systolic pressure. His LV peak systolic pressure will equal 140, and the pressure gradient here, or the peak instantaneous gradient, is 100. But we need to convert it into peak to peak. The way to do it is multiply it by 0.7. So LV systolic pressure will equal 140 plus Now, because the direction of the flow is from LV to the aorta, and the difference between them is this pressure gradient, which is 100. So 100 times 70% is 70. Now the LV systolic pressure will equal 210 millimeter of mercury. From that, now we can estimate the LA pressure from mitral regurgitation jet. Similar to estimation of RA pressure, we can estimate LA pressure from PFO or AST. However, estimating LA pressure is even simpler because RA pressure can be easily estimated from IVC. And once we know the RA pressure and we have PFO or AST, we can utilize this equation to estimate the LA pressure. Again, if LA pressure is higher than RA pressure, so LA pressure will equal RA pressure plus the gradient between them through the AST or PFO. If it is less and RA pressure is higher than LA pressure and we have right to left shunt, in that case LA pressure will equal RA pressure minus the gradient between the two chambers. All that what I mentioned in LA pressure estimation has some pitfalls that we need to understand. First of all, we have to understand that LA pressure, in measuring LA pressure, we assume that LA pressure is constant along the cardiac cycle, which is not true. We have LA end diastolic pressure, we have LA mean pressure, we have LA systolic pressure, so it's all different. The other thing is when we measure from MR, what we are measuring is the systolic LA pressure. When we measure it from aortic regurgitation, we measure actually the LA end diastolic pressure. We don't measure the LA pressure or LA mean pressure. In case of mitral stenosis, it's even worse because we are adding mean mitral stenosis pressure to the LV end diastolic pressure, which is something not physiological. They are happening at different timing of cardiac cycle. So when we add pressure or subtract pressure, ideally it should be taken from the same point of time in the cardiac cycle. However, since these differences are usually minimal in left atrial pressure, it is overlooked. Now I will talk about some abnormal connections. So if we have any abnormal connections, if we have any abnormal flow that we don't know it's coming from where or going to where, we have always to analyze this flow by continuous wave Doppler as well as pulse wave Doppler. By identifying the pressure gradient, the velocity of this flow at different phases of cardiac cycle, we can determine or guess what is or it's coming from which chamber and going to which chamber. For example, we have these two flows. Now, in that flow here, it's a predominantly systolic. We have a defect. We don't know exactly it's going from where to where. If it is going from, we think it's coming from LVOT to the RA. We call this sort of defect Gerbody defect. So in case of Gerbody defect where you have LVOT to RA, you have predominantly systolic flow. Why is that? Because during diastole, the LVOT and the whole of LV diastolic pressure is almost equal to the RA pressure or few millimeters of mercury higher than the RA pressure. So in that case, we will have predominantly systolic flow. However, if this defect is distal to the aortic valve, let's say between the aorta now and RA, now like in case of coronary artery fistula, from the aorta to the RA, you have high diastolic pressure as well as high systolic pressure all the time. So aortic diastolic pressure will be maybe 60, 50, and RA pressure is 5 or 10. So there is a pressure gradient between them all the time. In that case, you will have this continuous flow between the two chambers. This is an example how we can differentiate the site of shunt. Another example I will show you here. Now, let's say we have this color flow Doppler. We don't know where this shunt exactly is. Is it between LVOT and RA, or it's between LVOT and RV? We have this color coming here. We don't know exactly. So this is around 100, the pressure gradient millimeter of mercury. Let's say the patient blood pressure is 110. If this is a VSD, so a shunt between LVOT and RV, it will mean that the RV systolic pressure is 10. 110 minus 100, which does not make any sense. It cannot be the RVSP, and it means that this shunt is not between the LVOT and RV. However, it makes good sense that it is the RA, because RA pressure is 10, makes sense. So this is also another example how we can differentiate by knowing the timing and the pressure difference between different chambers. A quick mention of pressure half time. The pressure half time, it is the time it takes the pressure to drop by 50%. So from here to 50% of its initial value. It is important to realize that it is not the velocity which is dropping by 50%, it is the pressure. It is calculated from the continuous wave Doppler signal, where it can be automatically measured from this deceleration time. We have this deceleration time as follows. We just multiply it by 0.29 times deceleration time, we will get the pressure half time. We use the pressure half time in estimation of valve pathology like in mitral stenosis as well as aortic regurgitation. In order to complete the hemodynamic lecture, I have to mention the Valsalva maneuver. However, I have a detailed lecture of the Valsalva maneuver. I will put a link to it in the description below. Thank you for watching and for your patience in this intense lecture. The next lecture will be about the aortic valve.